Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I'd like to welcome everyone to the Journal Club, and I'd like to thank ESGO and IGCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recording will be made publicly available. Certainly, this is a great opportunity for us to have an in-depth discussion about this very important manuscript that was published in our journal. The title of the manuscript is the ESGO Eurocan GCIG Guidelines for the Management of Patients with Uterine Sarcomas. We're really very happy to have Isabelle Ray-Coquard, Sabrina Croce, and Martee Hensley. And hopefully Dr. Jalid Sehouli will be joining us as well. Isabelle Ray-Coquard is, of course, at the Department of Medical Oncology in the Center Léon Bernard in Lyon, France. Sabrina Croce is in the Department of Biopathology and Institut Bourgogne in Bordeaux, France. And then Martee Hensley is at Memorial Sloan Kettering in New York City. So we're really, again, very thankful and grateful that you have all taken the time to participate in this discussion. And welcome to the Journal Club, to all of you. So I wanted to first start by asking, and then certainly I'll start with you, Isabelle, with regards to what was the impetus to putting this document together, bringing all of this level of expertise and coming to the point of developing this important manuscript.
Thank you so much, Pedro, to give us the opportunity to discuss about this international worldwide guidelines. I have to say that I'm very happy and proud of this document because we have the great opportunity to invite several experts coming from everywhere at the worldwide level. I don't speak about any other planet, just speaking about our planet. And what also is very interesting is that we have the opportunity for the first time to bring the gynae community and the sarcoma community both together to try to resolve the question and to be sure that we are on the same line to propose quite standard of care, but we can discuss about the word of standard of care considering sarcoma patients to our patient. And one of the major reasons is to be sure that we agree about some very evident strategy we have to propose, to be sure that everybody agree on that, and for the future to build clinical trial where finally the control arm will be accepted by everybody. That it is something important. We are speaking about heart disease, and if we want to develop clinical trial in the future, we would need to be all together. Now, considering the methodology and the external reviewing, that it is not very easy speaking about rare disease where the level of expertise is not always the same for all the community. We use the methodology that we used before at the ESGO, but also GCIG level. We invite experts from the three different groups, that means from ESGO, from Eurocan, with a European network dedicated to rare cancer, not only rare gynae, and also GCIG, to listen very carefully our recommendation, guidelines, and sentence, and make comments on that. And then we have 2 days full meeting where we review everything and we adapt the wording by the people who review. That means that the reviewing were done by European, US, everywhere experts. Also, I have to say that looking to the fact that Eurocan and ESGO were more dedicated at the European level, it is possible that there is a little bit more European experts, external reviewer, than coming from Asia or South America at the end.
Excellent. Very well. So as you know, in the journal clubs, we always have our fellows in the journal participating, asking questions. We'll go to Jose Carlos Vilches in Malaga, Spain. who has, I believe, the first question for you, Isabelle. Jose, go ahead and please ask your question.
Yes, sorry, I was muted. Thank you, Pedro. Thank you, Isabelle. Okay, my question is, what role does play the molecular pathology in the diagnosis of uterine sarcomas or mesenchymal neoplasms of the uterus?
I guess it's for me.
I think the answer is for Sabrina, it's not for me.
All right.
Yes.
Okay, thank you for the question. Thanks a lot for inviting me. And it's important also a pathologist be invited by the clinicians. So definitive molecular pathology plays a crucial role in complementing histologic diagnosis, which is traditionally based on morphology, immunohistochemistry. So the molecular helps when you are quite sure in your diagnosis with histology, the highlighting fusions, this refine the diagnosis and okay, you say this provides a definitive confirmation. Sometimes you are not sure of your diagnosis because the morphology and immunohistochemistry are inconclusive, so molecular tests are unable to give an accurate diagnosis. Not only for diagnosis, but also for therapeutic strategy, to drive therapeutic strategy. Molecular can be useful, for example, in a low-grade endometrial stromal sarcoma, when you highlight a ESR1 hotspot pathogenic mutation, you can change your hormonal therapy. And again, I guess that it's very important to implement the molecular with the classical morphology and histology.
Excellent. So thank you so much. And again, I think it highlights the importance of having a very appropriate expert pathologist reviewing all of these cases. So that is critical and certainly part of the highlight of the manuscript. Now, I think this question will be for Isabelle from Elena Rodriguez Gonzalez in Spain.
Thank you. My question is, which could be the role of biopsy in suspicious myomas in women who want conservative surgery for reproductive desires?
Thank you, Elena, for this important question. As you know, the standard of care considering uterine sarcoma is not to move to biopsy and then to deliver hysterectomy, but to move to hysterectomy initially to have an en bloc surgery. However, we know that we have some tumor that it seems to be a sarcoma, but in reality is a benign lesion. And for young patients, that's be a big issue for the preservation of the fertility. And we have few data right now to propose this biopsy to these patients for several reasons. One is because of the trajectory of the biopsy, to be sure that we don't take the risk to disseminate tumor cell. And also because we know that the sample sometimes is not enough to confirm 100% that this tumor is a benign lesion. And we have published in France, but it is coming from one center. It's a preliminary data. You have to be careful. We are speaking about very expert infrastructure using dedicated team, including coaxial biopsy within the cervix, not percutaneous, including also CGS analysis, and this result for 34 patients or 35 patients were very encouraging, able to make a difference between benign and malignant lesion, that it could be something interesting for patients where we would like to propose only a myomectomy. But it is preliminary data, need to be confirmed by other center, and again in a very expert center, because there is some limitation and we have to be careful. But I'm thinking that Jalid want to say something on.
Yes, because this is, I think, one of the most difficult situation in the clinical day routine. But you know, there's no really a wonderful tool to discriminate between benign and malignant. Nevertheless, if you see a patient and there's a grow of a fibroid, it always depends on the location and in the age of the patient. So if it's a postmenopausal woman, it's a different approach. If you have a patient of 20 years of age. So what we have seen, and we have a registry in Germany for now more than 850 patients with sarcomas, many of the women have a morcellation in a postmenopausal status. And this, I think, is the wrong way. Nevertheless, if you see a patient with one fibroid, what is growing, peri or postmenopausal, if the patient has no bleeding, but she has anemia, if the patient has symptoms what she never had before, then you must be very aware for a sarcoma. What we do in this situation, we don't do morcellation. We add the CT scan to exclude lung metastasis. But in a young woman, I totally agree with Isabelle. If I have the selection to take the fertility of the patient, I would do a biopsy in these individual cases in a young woman before I take all the uterus out. So it's not one marker. It's even not the LDH. The latar dehydrogenase can be elevated, but it's not exclusion if it's normal. But it's like a puzzle, yes. But the first of the story is to be aware it is possible. And that's the reason why I strongly recommend to bring also clinical signals. And in general, if you have a fibroid what grow from 2 centimeters to 4 centimeters, that's in general not the sarcoma. But if you have a woman with 8 centimeters and it grow up to 12 or 15 centimeters, it's a different story. So at the end of the day, it's the awareness.
Well, thank you so much, Jalid. It's great to see you, and thank you for joining us. Not surprising, Dr. Sehouli at Charité was in the operating room when we started the discussion. So thank you once again.
I'm a little bit slow because I got my own surgery by my own hernia, and I have full of respect to Nets. So every patient we do surgery laparoscopically, I will stay them now for 1 month in hospital to catch the pain.
You must have a remarkable enhanced recovery after surgery program. You look fantastic for having had just surgery. So we'll turn over to Sabrina Croce. Lots of questions actually on pathology. This one is from Roberta Masorio in Italy.
Yes, thank you. Regarding pathology and molecular analysis, can a single molecular alteration reliably ensure an accurate diagnosis?
Thank you for the question. The answer is absolutely no. It's important to stress that molecular is essential, is complementary. Nevertheless, it's important to know that the same alteration, for example, PHF1, can be observed rearranged in low-grade endometrial sarcoma, as well in oxyfine fibromyxoid tumor in soft tissue and whatever. So always put what you find in the molecular in the practically precise context. Another example, once we make the diagnosis of low-grade endometrial stromal sarcoma, and we see we highlight by molecular SUX12, JADS-X1 and SUX12 fusion transcript, I say, okay, this is low-grade endometrial stromal sarcoma, and I'm done. No, because you have to know that in rare cases, but it's possible, a true low-grade endometrial stromal sarcoma can evolve, can transform. So as pathologists, it's very important to look for high-grade atypia when the tumors start to have necrosis, when you have a lot of mitosis, even if we don't have a precise cutoff, when you start to lose expression in RPR and cyclin E1 start to be strongly positive. Okay, this is just, but I precise, it was an X low-grade endometrial stromal sarcoma. This is an high-grade transformation. This is one. Another, you can have BCOR-L1 fusion transcript in high-grade endometrial stromal sarcoma, as well in adenosarcoma. So the morphology is still important. So I cannot anymore make the diagnosis without molecular, but again, the morphology is very important. Let me just to finish this question with the genomic profile. Even in a leiomyosarcoma, which is a undifferentiated uterine sarcoma, which is the gold standard for complex genomic sarcoma, you can find YE EY fusions. Okay, but you have one among a bunch of the other fusion. This is not driver. I don't change the diagnosis. So the final answer is take with attention any molecular result and put this in the morphology and the clinical context. Thank you.
Excellent, Sabrina. Thank you so much. And since we're on the topic of pathology, there's some questions that are coming in from the chat. And one question asked, what is the implication of a TSC2 mutation in leiomyosarcoma?
Yeah. TSC2 mutation is related to the PEComa. We associated TSC1, TSC2 mutation with PEComa. I'm always looking for this mutation in many situations. First of all, in PEComa. And when the PEComa is easy to diagnose in morphology, immunohistochemistry, but I need to go deeper. Type 1 PEComa, TSC2 mutated, and for you clinicians could be interesting for mTOR inhibitors. This is one part of the question. Secondly, leiomyosarcoma, because sometimes epithelioid leiomyosarcoma may be in differential diagnosis with PEComa, and sometimes is very difficult, believe me. Sometimes I'm not sure to say now the right. But if you find TSC2 mutation, this is not the only marker for PEComa. But I say, well, this tumor, at least you have to think about a PEComa. And if you don't find the other characteristic typical of a leiomyosarcoma, this could be also important for the therapeutic. Pay attention, recently, 2 years ago, the team of Sarah Chang described low-grade endometrial stromal sarcoma hybrid associated with TSC2 mutation. Probably they are low-grade endometrial stromal sarcoma, but for you clinician, it could be important to know the presence of this alteration because it's targetable.
Excellent. Thank you so much. And Jalid, we'll turn to you with some surgical questions. And I think Roberta is going to ask the next question.
Yes. Given that no imaging method can rule out sarcoma preoperatively and no preoperative scoring system is yet applicable to routine practice, along with findings of spillage in 9% of cases despite intact bags in minimal invasive surgery, can we classify minimal invasive myomectomy as a procedure that must not be performed? Or if not, what additional evidence would be required to justify this classification?
So first of all, we have to accept that patients who underwent morcellation have inferior overall survival. I think this is something what we have to clarify. The second topic is, I think it's not the case that we delete minimal invasive surgery in fibrate management. But again, in peri and postmenopausal women, we should not use it. This is a very clear statement based on our registry. In the young woman, there's no discussion. We have to inform the patient, and it's a rare disease, a rare situation. But I think we can minimize the risk if we use the clinical symptoms, what I already mentioned. But for postmenopausal women, I don't think there's any place. And even if you look on quality of life issue, you can do a very small incision to take it out without to make morcellation. This is my attitude. I don't know, Pedro. I think you are much more stronger in US using morcellation. It's still not allowed, huh? It's not still allowed?
Yeah. Yeah, and I, as you said, when you look at many gynecologic oncology departments, they don't even have a morcellator. And in fact, actually, I remember when I was back at Anderson that one of our general gynecologists suggested to actually acquire a morcellator, and the decision was made not to even actually have it available. So Jalid, I wanted to actually ask you a follow-up question to that, because there are some who will claim and say, well, I put it in a bag and it's completely protected and nothing's going to get exposed. Concerns with that?
I have never seen an use of endobag without spilling cells. So this is, so I believe in God, I believe in many things, but I don't believe in this endobag. So I think again, and I have seen so many patients, it's a bias, okay? But I have seen patients with a very small tumor and we did morcellation and we lost the patient. We lost the patient. And that's not only one case. So I don't want to go to risk for my relatives. I don't want to go for risk for any other patient.
Very well. Excellent. So, Dr. Hensley, we've been waiting to hear from you, and we're excited to hear from you about some of the medical and hormonal related questions. Elena, I believe you have the next question.
Okay. Yes, thank you. In the case of a stage 1 low-grade endometrial stroma sarcoma where morcellation has been performed, would adnexal sparing be appropriate? Would adjuvant hormonal treatment be recommended?
Well, I think as you've been hearing, we have concerns about morcellation, really almost no matter the grade of the tumor. And I would say in general, I recommend a hysterectomy and removal of the ovaries for all patients with low-grade endometrial stromal sarcoma. I'll say that as a top-line thing, but of course, then one has to consider age and maybe the stage of the tumor. I think if a patient very strongly favors fertility preservation, she has to be counseled about the high risk for recurrence. Patients who've had a myomectomy, which you could think of as conceptually similar perhaps to morcellation, do have a higher risk of recurrence, at least in one study, 79% versus 25% if they'd had a hysterectomy. And because the risk for the recurrence in the low-grade ESS persists really for decades, patients who do elect fertility sparing, they may still want to think about a hysterectomy and BSO after childbearing. This hasn't really been studied, but we know that we can see low-grade ESS come back 10 and 20 years after a diagnosis. As far as adjuvant therapy beyond BSO, which may not be exactly what you were thinking, but when I see a premenopausal woman who's definitely premenopausal at the diagnosis of her low-grade ESS, even if she had a morcellation procedure, but then you go back and you take the ovaries out, I often counsel her that surgical menopause can be considered her adjuvant therapy. I would not necessarily commit her to long-term treatment with an aromatase inhibitor sort of on top of the surgical menopause. In a postmenopausal woman with low-grade ESS who's had a morcellation, I might have some consideration about using an aromatase inhibitor in that setting. I would say that it's not so common that I see postmenopausal women with low-grade ESS. Most of them are perimenopausal or even premenopausal. So hopefully, I think that addressed most of the question. If there are others on the call that want to follow up.
Yeah, and as a follow-up question to that, you talked about conservative management of keeping the uterus in the setting of low-grade endometrial stromal sarcoma, the wisdom for that or against that. What about in the setting of if a patient presents with an adenosarcoma diagnosis where they had just a myomectomy? Do we feel comfortable saying, well, it's okay to preserve the uterus and it's okay to consider future fertility?
Even more difficult, I think. Adenosarcomas are even more rare than low-grade ESS. Here, and Sabrina may want to chime in, but for me, when I see the adenosarcoma diagnosis, my concern is whether it is a true low-grade adenosarcoma with no high-grade features, no sarcomatous overgrowth. When I see an early-stage adenosarcoma with sarcomatous overgrowth, I kind of put that in my head category as really a high-grade tumor with a high risk for recurrence. I would be very nervous about leaving the uterus, and I would still, even with a hysterectomy, I would counsel her about the high risk for recurrence. an absolutely low-grade adenosarcoma and like a little tiny polyp that's clipped out cleanly, I may be comfortable letting her keep her uterus. Again, a little bit data-free zone. So if others may disagree.
Yeah, no, it's a really good point. And I'd love to hear Sabrina's comments about the component of sarcomatous overgrowth as well, because particularly for our listeners and those who have joined the Journal Club, the importance of having that discussion with your pathologist as to whether there is sarcomatous overgrowth.
For me, yes, absolutely agree. And the sarcomatous overgrowth is, for now, the most important prognostic factor, even more than the infiltration. And this is essential to highlight the presence of this. The problem is when you make the diagnosis on the microbiopsy or in a curating, it is possible to not analyze all the specimen. So probably in the biopsy, you say low-grade adenosarcoma, if you are lucky, because sometimes you don't see the glands. So we have to be sure that the lesion is well sampled. What you see is representative. But when sarcomatous overgrowth, especially when it starts to be P53 mutated, is very aggressive. And I'm not sure there is a lot of therapy for this complex genomic sarcoma.
Excellent. So this next question, and I think we sort of alluded to it already before, but Susana Del Frati will ask the next question.
Yeah, it's linked with the previous question. Thank you. I would like to ask, under what conditions does the guidelines recommend ovarian preservation in premenopausal patients with early stage uterine sarcomas, and how should the risk of recurrence be balanced against the benefits of preserving hormonal function? Thank you.
Yes, I'm happy to address this, and it is a little bit different than the question that was specifically about low-grade ESS, where we think of the tumors as so clearly driven by hormone production. For a high-grade uterine sarcoma, high-grade endometrial stromal sarcoma, high-grade leiomyosarcoma, we really don't have data that a BSO will improve survival. The risk of recurrence in those patients is, of course, very high. You know, the estimates for a uterus-limited high-grade tumor recurrence could be 50 to 70% risk. But doing a BSO has not been shown to alter that risk, of course, not in any prospective randomized way, but looking back at SEER data, for example. Also, many high-grade endometrial stromal sarcomas are estrogen receptor and progesterone receptor negative, so we don't have that same sort of logical link between the BSO and outcome for those high-grade tumors. As you've already heard from others, hysterectomy without morcellation would be recommended for high-grade tumors. And of course, we don't always know whether it's going to be a high-grade tumor, but if you suspect so, I would certainly avoid morcellation in that setting. And then just thinking about, well, why not just take the ovaries? In a premenopausal woman with a uterus-limited, even high-grade leiomyosarcoma, if her recurrence risk is between 50 and 70%, her cure rate with surgery alone is 30 to 50%. So choosing to put her in an early menopause of 10 years, for example, could be detrimental to her. So I have a very calm conversation with young women about doing a non-morcellation hysterectomy, but perhaps with ovarian preservation, even in high-grade sarcomas. It's a little more nuanced if you have a patient who's had a hysterectomy, the ovaries are still in, it's a leiomyosarcoma, it's strongly estrogen positive, but generally we have not gone back in that setting to tell her that the ovaries have to come out. And then, you know, as I'm thinking of my answers to these, this is a really difficult situation. We only have retrospective data. And one question that comes up in my mind is that leiomyosarcomas that are estrogen receptor positive might just be biologically different than those that are estrogen receptor negative. And we go back and take the ovaries out and we think we're doing something, but maybe it's the biology that drives that better outcome and not the hormonal intervention. Unproven, but a thought.
Excellent. So, Jalid, we'll turn over to you. Raikant Boladrekova from Kazakhstan will ask the next question.
Thank you. My question is, open total hysterectomy if the recommended treatment in case of preoperative suspicion of early stage of uterine sarcoma. Are there specific criteria that would justify a minimally invasive approach?
No. If it's really suspicious, you not do it laparoscopically. I think this is clear. If it's a very young woman, think about biopsy, what we already addressed.
Excellent. Susana Del Frati has the next question. Go ahead.
Yes, thank you. How does the guideline address the management of incidental sarcomas diagnosis after morcellation during surgery for presumed benign conditions? And what follow-up imaging and treatment strategies are recommended? Thank you.
So, Jalid, how do you follow up these patients?
So first of all, to do a CT scan, I think it's very important to look if the patient has lung metastasis. From the literature, up to 10 to 20% have already at time of primary diagnosed lung metastasis. So I think this will be the first step. The second topic is if the uterus still in the abdomen or not. And we already touched this topic. If you have residuals, you have to do surgery and to remove the residuals, because you have no other control mechanism to manage this. Yes. So the discussion, if chemotherapy can be given, maybe Isabelle and even Martee can add. So there's no robust data for this. There's no recommendation to give chemo in these higher risk situation. And at the end of the day, we talk individually with the patient based on the histology. It's a high grade sarcoma. It's a different thing if you have a low grade stroma sarcoma, for instance. But you cannot go on data that you make chemotherapy, even with a combination, as a mandatory approach. But in the individual case, we will discuss it. But it's maybe even over treatment, and even maybe a treatment due to the fear of the surgeon and the patient, but not based on the robust evidence we can offer. But this will be the algorithm, what we will do in our center, and this is what I will comment. But maybe Isabelle and Martee can add.
No, you're right, Jalid. It is really the every week's meeting in the multidisciplinary tumor board, and I'm pretty sure that we did not take the same decision every time, because we integrate other factors. Why? For two reasons. First is that we know the limitation of chemotherapy for sarcoma patients. We are not speaking about platinum-based chemotherapy for ovarian cancer, high-grade serous, where we know the real sensitivity of the tumor cell to chemotherapy, that it is not the case for sarcoma. The second point is that, as you mentioned, we never seen a good chemotherapy able to repair a worse surgery. We are not able to be better than a good surgeon. So it's really important to remember that. There is no chemotherapy able to change the story when the surgery was not done in the right way.
Yeah. And Jalid, going back to the topic of surveillance, and I know that there's a lot of variability, and I was wondering, what is your own practice in that? You know, we have the patients who have morcellation, they had post-op chemotherapy for hopefully preventing recurrence. And then they're asking, well, do I get a PET scan? Do I get a CT scan? Why don't I get a PET scan? And am I getting it every 3 months for the next 5 years? Should I get it every 4 months? What is your approach?
Even in the guideline, we discussed this very, very emotional. There are even doctors, what we not agree to do a second look laparoscopy, after 6 to 12 months, but that was not based on our consensus, so we deleted from the story of our guidelines. So what we do every 3 months the clinical examination, but we add in the first year, we will add CT scan additionally. What we also add, but it's only marginal, we do even CR1 to 5, but we know that this is a very fragile marker, but only to get a feeling, because at the moment, even if we detect a leiomyosarcomatosis, we cannot give the patient the evidence that this patient will be better treated if we go in the early diagnose, yes. But nevertheless, in the first year, we have a very close monitoring, and we will add CT scan in the first year. Every 3 months, we will do this.
Excellent. So this next question to Martee Hensley from Susana Del Frati.
Yes, thank you again. And given the aggressive nature of high-grade endometrial stromal sarcomas and undifferentiated uterine sarcomas, what are the indications for adjuvant chemotherapy in stage 1 disease? And how does this align with current evidence on recurrence rates? Thank you.
I very much wish I could quote a randomized phase 3 trial to show outcomes in this situation. But we do not have prospective data showing improved survival outcomes in non-morcellated uterine confined high-grade endometrial stromal sarcoma after a hysterectomy, whether the ovaries came out or not. I tell patients that yes, the risk for recurrence is high, same as I tell a patient with a uterus confined high-grade leiomyosarcoma, but that the use of chemotherapy agents that may be helpful in metastatic disease have not been shown to improve survival in uterus confined disease. I try to be careful that patients don't walk away hearing that chemo doesn't help in sarcoma, because then they come back to me with recurrent disease and say, hey, you told me it wouldn't help. I try to say we have drugs that work adequately to help us control but not cure metastatic disease. But those drugs are not sufficiently wonderful that they eliminate the risk of recurrence in early stage disease. So for me, I recommend surveillance, which circles back to the question that we were just talking about. And I do surveillance with imaging. I usually choose CT scan over PET because I think the risk of asymptomatic bone metastasis is low and the radiation exposure is higher and the expense of PET is higher. And in some of my low-grade ESS patients or my young patients, I will sometimes choose MRI of the abdomen and pelvis. And if it's a low-grade ESS, even chest X-ray for the lung, since that minimizes her long-term radiation exposure. She's going to be imaged for years and years. My high-grade patients, I image more frequently in the first 2 to 3 years because I think the high-grade cancers, the bad ones, come back quickly and are less likely to come back later. Thanks.
Great. And Martee, since we have a question from the audience regarding the use of doxorubicin and trabectedin. And the question is, would you use doxorubicin followed by trabectedin in resected leiomyosarcomas?
So the data that were reported in the New England Journal of Medicine showing an overall survival benefit from the randomized trial of doxorubicin plus trabectedin followed by trabectedin maintenance versus doxorubicin alone in patients with metastatic leiomyosarcoma who were chemotherapy naive. Patrice Potier's study, very exciting advance for patients with leiomyosarcoma. If you can't tell by my answers, I tend to try to be a very data-driven person. And when I make decisions, I try to ask myself whether the patient would have been eligible for the trial. So in that study, the patients had measurable metastatic disease. And I think that first-line treatment with that regimen is very reasonable for patients who are fit with good organ function, and perhaps particularly with patients with a larger volume of disease. We do not know whether those data apply to patients with no measurable disease, but who are at risk for recurrence. And I have not been using that regimen in that situation thus far, although that may be different than you would hear from other people on the panel.
Isabelle, I see you nodding. Your thoughts on that?
Yeah, you imagine that since the phase 1, we were very interested by the response rate we see with the combination. And as Martee is saying, the data we have right now is for advanced, because we have the possibility to include stage 3 patients, advanced and recurrent disease. And we need to be focused on that. And we have to remember it's only one large phase 3. We have right now another ongoing phase 3 trial exploring the combination, not with trabectedin, but with something similar that will be detected in. And I encourage the patient to be included in this clinical trial. It's always better to have 2 clinical large phase 3 reporting benefits in terms of PFS and overall survival. However, due to these results, we are starting in Europe a large phase 3 for localized disease, where the patient having a SYNSARC signature reporting a huge risk of relapse, looking to the SYNSARC signature, could be randomized to receive this adjuvant treatment versus surveillance, because surveillance continue to be the standard of care for localized disease. So we have 2 ongoing trials reporting the activity to support the New England Journal of Medicine paper, and I'm very proud of that.
Really great. And one last question for Sabrina from our audience. Can you tell us about the differences between an undifferentiated sarcoma and a high-grade sarcoma?
Yeah. First of all, the distinction was morphologically. In 2008, Kurihara described among the undifferentiated urinary sarcoma a uniform type from the pleomorphic. And actually, after RNA sequencing, especially from the group uniform undifferentiated uterine sarcoma, we are able to distinguish, to tell apart the high-grade BCOR, the high-grade YE. So actually, the high-grade endometrial stromal sarcoma and undifferentiated uterine sarcoma uniform type can be the same. I mean, before the RNA sequencing, a lot of high-grade we were able to describe the other subcategory. Sometimes there are some undifferentiated urinary sarcoma, I call it like this, and actually I am not able to highlight the fusion. And in this case, probably there is no distinction. Another point that you can also call high-grade endometrial stromal sarcoma, the high-grade sarcoma developing from low-grade JAZ1, so probably is not the same.
Excellent. Well, thank you so much. And as we come to this conclusion of the Journal Club, I'll let Isabelle say the closing remarks. What are your thoughts on how this information should be used moving forward by gynecologic oncologists, medical oncologists, pathologists, radiation oncologists, and your recommendation to our audience as well?
Thank you so much, Pedro, to give me the opportunity to say some word. I would like for sure to thank not only the International Journal of Gynae Cancer to speak about uterine sarcoma patients. We have to remember that they are not so rare. But I also would like to thank the GCIG, Huracan, and ESGO, who give us the opportunity to take time for this patient and to bring our knowledge and the data available in the literature to make some digest for our friends. And I hope that the smartphone application from ESGO will be available for uterine sarcoma soon to help you in your daily practice. We have to remember that it is really the management in expert center who is very important for this patient. No place for amateurism, considering the huge risk of relapse if the surgery is not done as we have to do. And with this guideline, I'm pretty sure that large phase 3 at the worldwide level will be available soon for our patients to change the story.
Well, thank you so much, Sabrina, Martee, Jalid, and of course, Isabelle. We are really very fortunate to have had this opportunity to have this discussion, to learn from you. I want to thank you and all of the other collaborators who participated in the development of this guidelines and manuscript. And I really, truly do want to thank all of you for your continued contributions to the field of gynecologic oncology. Really, truly admirable. Thank you.
Thank you. And for supporting this. Thank you very much. Bye-bye.
Thank you so much for the opportunity.
Thank you.